All right, welcome back to Insights of All Trades. I'm here in Wilkes with Cole.
Oh yeah, the great metropolis of Wilkes-Barre.
Yeah, so we have an awesome guest coming on today. We'll get to that in a minute, but first we have our own not our insight, but like a borrowed insight from one of the many books on our reading list. This one comes from Michael Pollan, he has a new book out, Caffeine and How Caffeine Created the Modern World. And so his quote here says, "It appears there is no free lunch. The energy that cup of coffee or tea has given you has been borrowed from the future and must eventually be paid back. What's more, there is interest to be paid on that loan, and it can be calculated in the quantity and quality of your sleep." So we talk about sleep a lot on the show, but another thing that we don't always bring up so much is like the effect of substances and specifically caffeine on your sleep. And so I know personally I'm trying to like stay away from caffeine as much as I can, but oftentimes you really just do need it. Like you're not going to get through the day without it. I know Cole and I were kind of comparing our caffeine intake before the show, and what you said you take how much like per
So
day?
I'm a raging caffeine addict, and it's my chosen vice. I've probably, uh, well, not probably. I for sure have like 400 to 500 milligrams every day of caffeine through the mediums of coffee and energy drinks and Zip Fizz and 5 Hour Energy. Um, it is for sure my drug of choice, mainly because of studying. I was talking about with Nick off camera how I felt like I could go through busy work related things without caffeine, but for studying, it's such a good legal performance enhancing drug.
Yeah, it's true. I mean, if I just sit, I mean, I do now. I have to sit and study all day long for this stupid boards exam coming up. But if I'm just sitting there without any, like, I try to keep my intake to a minimum. I'll have like a cup of tea if I'm really feeling it, or like a cup of coffee. But man, if I don't have any caffeine in me at all, I'm just sitting there like basically almost dozing off. You can't stay focused on it. It's just, I mean, for better or for worse, you really do need it for things like that. I don't really know the other way around it, other than getting better sleep and more sleep. But then then you're cutting out more time from studying. So
Yeah, this is such a bad way to go about it, but if I'm being totally honest, like I know on the other side of that, the healthy, just as productive side is shifting to like you titrate down your caffeine until you have a very good sleep schedule.
mm,
But I know that there's an in between phase where I will sacrifice a lot of productivity, a
yeah,
lot of studying hours while I'm catching up on sleep, and I'm like, oh well, I feel like I need to be waking up for early for this exam, but now I'm playing the catch up one. Or like, if I'm
yeah,
trying to get my sleep in control, that means I'm getting at least 7 hours. With where I'm at, probably well over 7 hours if I wasn't caffeinating,
yeah,
and then going through like the withdrawal headaches of caffeine. So instead, I put it on the back burner. Like, I really just need to tackle these
yeah.
objectives right now and focus on after classes dialed down, titrating down the caffeine to maybe like 100 milligrams a day, or who knows, maybe someday just not having caffeine. That sounds like an insane concept to me right now.
Well, on top of that, trying to titrate down, like something will randomly come up. You'll get sick in the middle of it, and you'll just be wiped out anyways, and you'll have to go to the caffeine. I don't know. I don't have a great solution to it. I think it is one of those things that kind of like the quote that Michael Pollan says, where you're just that cup of coffee is really just borrowing from the future. What you're going to need to at some point titrate down and try and get better sleep if you're health conscious. But I don't know. I guess we don't have a solution. We just are presenting what he says as like this is what the fact is. So I don't know if it's necessarily an insight, but more just like a this is what's going on.
Speaking of substance use and how to best handle coming off of substances that you
Yeah.
are using. Our guest today, my good friend Harrison Ferro, he is like a wizard when it comes to talking about the evidence behind substance use disorders, both in terms of how they're affecting the world and how, physicians and pharmacists and the industry should best go about kind of tackling those problems, whether it's like the stigmas that go along with it, or the treatments for it, or the antidotes for overdose. It's very fascinating, and basically my whole pharmacy school sees him as like the ultimate resource for things relating to substance use disorders. So it's great to have him on.
Yeah, I really enjoyed the conversation. I think he does a great job of painting the picture that, everyone really knows somebody that, whether it's substance use disorder or alcohol use disorder or depression or anxiety, everyone pretty much knows somebody close to them that has some sort of a mental health thing that they're struggling with. So it kind of just puts the prevalence of that in the picture, and he is very knowledgeable on these topics. So it was an awesome conversation. So stay tuned for that, and here we go.
Welcome to Insights of All Trades podcast with Nick and Cole. This is where we talk with people we meet along our journeys through medicine, military service, sports, education, and beyond. We hope you enjoy. And we are rolling. Harrison Ferro, what is up, dude?
Hey, it's good to be here.
So we were talking before we got rolling here about your radio show a little bit. Can you tell us a little bit about that?
Yeah, so last year, myself and another pharmacy student, Dylan Fox, he's a fourth-year pharmacy student now, we started our, what we call our Generation RX radio show. We need like an actual title for it, but we have a weekly show on topics related to the opioid epidemic and substance use disorders, naloxone, and medication use as a whole. It's kind of, I don't know, it's like one of those, I don't want to call it Venn diagram. Like, the family tree like branches out sometimes. It's just like, all right, here's where it started, and you go down, and it's just like all this stuff we talk about. Sometimes it's random, but yeah, it's fun. I like doing it. So it's kind of nice doing this. We're actually trying to make it a podcast now. So might need some help with that down the road, but
I don't know how well versed we are yet.
Yeah.
We're still getting our feet wet a little bit.
We're working on it. So what kind of like topics do you normally go over on the show?
Yeah, well, we kind of set it up to almost tell a story. That's how it was initially, was, all right, here's our show, but what is it about? Because, we're the show goes out to like Wilkes-Barre area. It's Wilkes-Barre, Scranton, and Hazleton. So pretty much this county and the surrounding. And so we had to kind of set like the preface for it, like what's this show about? So we talked about our organization. So Generation RX is a national organization, but each school of pharmacy has like their own local chapter.
Oh, so like each pharmacy school has like a Generation RX radio, or just just like the Generation RX in and of itself, and you have like began the radio station affiliated with Generation RX.
Is that kind of like the AAMC stuff for like medical? Or?
Yeah, kind of. Like, so there's the organizations, like ours is within the American Pharmacists Association, but there's like, I mean, Cole, there's like 1 million pharmacy organizations, and it's kind of crazy. It's like there's one for like anybody and everybody, but the American Pharmacists Association is kind of like,
might be the biggest.
Yeah, it's like the official body of like for pharmacists. Like that's who it's like, if this body of pharmacy supports something in legislation, like when they're going to pass a pharmacy law, they want to look and see that they're backing it. But anywho, so each school has their own APHA chapter, and most of them have a Generation RX chapter within that. Ours is the only, to our knowledge, we're not trying to brag by any means, but ours is the only one with a radio show, to our knowledge. And that's something we're really proud of. We're trying to expand it and make sure we can make it more sustainable. And we were talking a little bit before about this, but just like the longevity of it. Like you had asked about like the topics. So like a lot of it, it builds on each other, but it's like, it can be a lot of repeat stuff. So it's like, all right, we have to be careful about that. For instance, like when we started the show, I was saying we were telling a story. So we talked about what Generation RX is. Well, if we talk about, safe medication disposal and the dangers of misusing medications every week, well, what are we doing new, right? Like, it's just like, all right, we're just doing the same stuff. Like, you need to do something else. Otherwise, people are just going to tune you out. So we started with that, then we moved on to the opioid epidemic. And then within the opioid epidemic, then we talked about substance use disorders. We talked about, illicit opioids, and now we're actually talking about stimulants. So stimulant use disorder, which is kind of on the rise right now. We're doing an okay job at like tackling like the opioid stuff. Still not there. I think when we were at Care Lab the other day, Franco described it pretty well. Like our foot's on the gas, and you don't want to take your foot off the gas.
Yeah.
Yeah, I know he said that was the first year in like 5 years that we saw a decrease in PA of opioid overdoses.
Yeah.
Maybe I just think this for some random reason, but isn't it kind of worse up here in like the northeast part of the state than a lot of the rest of the?
I wouldn't say it's worse. We're definitely on like the lower end of, and when we're in the top 10, I guess, of deaths. Like this side of the state is. I'm trying to remember off the top of my head. There's this report that the DEA put out.
Okay.
And I think last year, in 2018 anyway, I think Luzerne County was like ranked 7th or 8th. But it has kind of moved over from the like western part of the state now to like the northeast.
Okay.
I'm trying to remember. Montour County was number 1, which is crazy because Montour County is like really, really small. Like,
is that where Danville is?
Yeah, that's where Danville is. So like kind of not center, but a little around the center of PA, but Montour County is so small, and it's like they had a lot of deaths compared to other parts of the state. By no means, though, is Pennsylvania like the worst state off. I mean, Ohio and then West Virginia. It actually they say like the opioid epidemic really started in West Virginia, which
yeah, that makes sense.
Or not West Virginia, Ohio. Sorry,
okay,
Ohio.
Either way, that makes a lot of sense because I know it's a pretty big issue in Pittsburgh, which is like right there between Ohio and West Virginia. So it would make sense that that's kind of where it started, and it's been spreading its way.
Yeah, if you look at there's these past reports that the DEA has also put out. Pittsburgh and like around Pittsburgh area used to be really like those were the hard hit areas in PA, and then it just kind of started spreading off towards the east side of the state. So yeah, there's definitely like a trend like moving towards. I mean, now it's kind of even like throughout each county, but that you could see it over the years if you look at the DEA reports that they put out. Anyone can get those too if you ever want to look at it.
How far back does that go?
They started taking record of that specifically, like opioid deaths, like and making sure they tracked it every year, starting in I think 2013 or 14. But all of it is public information if you ever want to check it out. Like if you Google like DEA report PA, you can find last year's. Just put the year in, and then it should give you like the first one that'll probably come up is 2018. That's the most recent one. The 2019 one should have came out by now, but they're running a little behind. It's a lot though. Like they really, like for our show, like that's what we really based a lot of our the first 5 or 6 episodes, because we had so much information. Like they have they talked about like how much like the DEA has seized. Like they found out where it was coming from, where it was going, who was buying it, how much of it was being sold as like synthetic illicit opioids, and how much of it was like actually like nothing, like drywall dust or like just like just some powder. Because I mean, if someone's telling you it's meth or cocaine, for all you know, like what is it? I mean, those aren't opioids by any means, but a lot of these things are mixed too. Yeah. So people are taking like fentanyl, which prescription fentanyl on its own is like 100 times more potent than morphine. So that's why like fentanyl patches are like in micrograms where morphine is in milligrams, because it's like 100 times more potent. But this illicit fentanyl that they're making is like 1,000 to 10,000 times more, and that's why someone takes it once and they're gone. And yeah.
So is it like the early like 2010s ish, whenever people started recognizing it might kind of be an issue?
That I'm not sure of, but
that's when they started collecting.
Yeah, they started to take data. That's something I've actually been trying to like look at when they started realizing like, all right, we need to really like start getting a handle on it. And I mean, most of the strategies they've started using, the DEA, the state started in like this past decade. Like they started like the take back events that are throughout the state. If you've ever seen those where you go and bring in your meds, like those started in 2015. That was like the first year for that. So like only in the past 5 years was that started. Like naloxone now has a standing order, meaning you can go into any pharmacy and get it without a prescription. That is in the last...
Right, and naloxone is like the antidote to opioid overdose.
Yeah, I actually have some in my pocket.
Oh man, we might have to break it out.
I could get it. It's I keep it on me. I'm a firm believer in if you're going to preach something, you got to back it up. So like I was telling my friends, pharmacists, like people I work with, like, oh yeah, everyone should carry naloxone. Like we were preaching it on our radio show, Dr. Franco and I and Dylan. And then I was like, you know what? I don't have it. And I'm like, I was like, to me, if you're going to preach something, you got to do it too. Like you have to follow your own, like what you tell yourself in your mind you practice, you need to actually do that. Mm-hmm. So I actually set up an event where we had pharmacy students go to a giveaway day. It was an naloxone giveaway day. And the students showed them how to use it, and then all the students got some, I got some, Franco got some. So when he was talking about that the other day, that's where he got it from. But I was glad. That was the start of last semester. I was like, all right, it's about time, because it is pretty costly if you.
What's the out-of-pocket cost?
Like roughly like $130 to $150.
But most insurances would probably cover it, right?
Yeah.
If they have a prescription.
Yeah. So well, you don't even need a prescription like to have it be covered technically. I mean, they do run it. So the way it works. So like with your typical prescription, you go into the pharmacy and they bill it, and there has to be a doctor written on there. So it's like, all right, how are you going to make a prescription when there's no doctor? Well, there is one. It's
So the Attorney General?
It's the physician general for the state. So it's Rachel Levine. I forget how to say her last name, but she is the one who signed the standing order. And the standing order means that anyone can get it without a prescription. So her signing that is pretty much like the prescription. So like when we go and fill a prescription in the computer, we type all this stuff in, we put her in as the doctor, put naloxone in as the drug, and then just use as directed, whatever. I've actually never filled one.
So can you bill the insurance?
Yeah, you can, because you need a doctor to bill the insurance. So she's the doctor you'll use for that, and then it depends on where you're at. And we learned about how insurance, sometimes you pay more at the start of your when your insurance kicks in, you're going to pay more to reach your deductible. So that's why someone might say, well, they billed it and it still cost me $130. And it's like, well, if your plan just started, it's gonna. So some people can get it for free. If you have Medicaid, they should cover it for free. So Medicaid is like for more low income individuals, so they can get it for free. But anyone can get it. You don't have to be on an opioid. There's a interesting article though that another student sent me about that. There was an insurance company that was denying someone their life insurance claim because they had naloxone on their so like because they're thinking like, oh, you have naloxone, so you're using something, you're like, this person's just going to die, you're just trying to get this money out of it. And it's like, that's not what was happening. But I have
like an extreme version of stigmatizing.
Yes, very, very stigmatizing. So that's something we talk about too on the show, is stigma. Like most people don't seek treatment for a substance use disorder because of stigma. Like they may be ashamed of it, like their family, their friends, like there's a lot of shame and stigma about it. Even like going into a pharmacy and like asking for naloxone, like that's tough. Like imagine going in and it's like, what's the first thing that pops into your head? I did this with my mom. I was like, all right, I'm going to pretend I'm a kid walking into a pharmacy and I ask you for naloxone. What's like your first thing? And it's like, oh, you're using drugs. Oh, you're going to hurt yourself. Like something like that. So it's hard. And like, that's your initial, like, it's just like almost like built into the brain. It's like this is bad, like all these red flags, if that makes any sense.
Yeah. Even you can probably build off of this a little more eloquently than I can, but even when, pharmacists see that someone has a new opioid prescription, it's kind of our duty to bring up that they can benefit from having naloxone
Oh
on
yeah.
hand.
Mm-hmm.
And those patients, regardless of the age, they may feel like they are then being,
Oh
so,
yeah.
yeah, like attacked because they very well, could be not misusing it. They probably aren't statistically
Yes. Yeah.
misusing it, and they're probably
Mm-hmm.
using it totally responsibly. But as the pharmacist, you don't know that, so you're just backstopping them
Uh-huh.
with offering them naloxone.
Yeah.
So how do you, I guess, circumvent that?
Yeah. So here's the way I've taken an approach to it. And there's actually, if you ever want to look at some nice evidence-based counseling points on this, there's an information sheet that's out there called Let's Talk About Naloxone. I think I might have some in my bag, but it's like a double-sided sheet on like, here's some key terms you can use to bring it up that are like a non-attacking way, I guess you could call it, because I like kind of what you said, like it's just like the patient might be very uncomfortable or like, oh, you're calling me,
An addict.
yeah, which that's the term, and I'll get into terminology later. We talked about that too, but the way I typically go about it is let's compare it to someone with diabetes. So, and we learned about a lot of the medications used for treating diabetes cause low blood sugar. And we're not ever hesitant to tell someone, keep some sugar around. Here's a glucagon syringe to, get you up and running, because you can die. Actually, someone I work with just passed away from it, like
From like a
hypoglycemic
hypoglycemic
event.
incident?
Yeah. So, and it's just like hypoglycemia is very like it's severe. Like you can die from it. So the way I bring it up is, hey, with our patients with diabetes, we offer them this because it's a life-saving medication that will help you in the event that your medication causes you harm. And it's the same thing with opioids. They come with a black box warning of respiratory depression. That's what an overdose is we call it an opioid-related breathing emergency. It's a stigma reduction technique. Because when you think drug overdose, like what are you thinking? Like, oh, someone's just getting high off of it, right? Well, no, what happens is the opioids are good at treating pain, but they also, in binding to the mu receptors, they'll decrease pain. They'll also decrease your respiratory drive so that you have slow breathing. And when once their respiratory rate gets low enough, they're unconscious, they're unresponsive. That's where the blue lips and fingertips comes from, like as a sign or symptom to watch out for. So that's what causes the actual overdose. So that's what naloxone does, is reverse it. So I kind of tie it back to another disease state where we offer another medication. So, but it is tough. Like I've never had to do it in practice yet, just because I work in a hospital.
Right.
So like I don't really see patients a lot, which is I found like I like actually talking to patients, but I really dislike billing insurance companies. Yeah. I hate I'm just not a fan of how like the community pharmacy profession currently is, with like you're just tied up with billing things, and I feel I get so stressed out over that, and I'm more worried about making sure that claim is processed, because at the end of the day, like whether it's an independent pharmacy or if it's a chain, for the independent pharmacy you got to bill that. Like that's what's keeping them in business, like filling prescriptions. If it's a chain, you got to meet your quota. And if you're not meeting your quota, your district manager is going to come down and ask you why you're not doing as well as the other stores, and then they're going to say, all right, we might have to move you.
So while we're on the topic of trying to tackle or at least confront stigmas related to substance use disorders, we hear a lot, maybe not so much from healthcare professionals, but from patients. And even if you just hop on social media, this idea that addiction isn't a disease and is entirely self-induced, and the continuation of that addiction is only a choice. How do you address that? Actually, you don't even before you talk about addressing that, like how do you deconstruct that?
This is the same way I actually study. I go back to the mechanism of action. Whenever I'm like thinking about side effects of something, whenever I'm thinking about disease states, whether it's the treatment for one or what causes it, like the pathophys, I think back to what caused it, like what causes it. So let's say, I'm trying to think of like something, what's something you really like to do that just like gets you like that runner's high per se?
Running.
Yeah, besides running, yeah, I like running too. I used to get it, now not so much anymore.
Probably lifting.
Right, like you feel good, right?
Yeah.
It's like,
I think it's my ego just getting like a good pump on
Yeah.
arm day, dude.
Mhm.
It's not like I'm a big guy, but like it really
a lot
massages the
bigger than
ego.
me.
It massages the ego
Right.
real well when you have a good arm pump going.
right, yeah. Let's say like you walk out, it's almost like all this stress, everything else is just like gone. It's like you're in the moment, like, wow, I feel great right now. Like this is amazing. Like I can't wait to do this again, right? Like you look forward to that then.
Right.
So I kind of tie it back to that, where like when people like even getting a thrill out of like skydiving, like some people think skydiving's insane. It's like,
But we might
ooh,
have to
we
bounce
might-
around. You
yeah.
can keep going. Nick will get the lights on.
Oh yeah, they're like motion sensor. Yeah. So what I'm getting at is here you're getting like a euphoric like effect per se. Like you're getting this like rise in dopamine. That's like, wow, I'm feeling great right now. Like this is
Right.
awesome. So I tie that into what opioids do. So ultimately, I'm going to really simplify it because there's a lot more that goes into it. But essentially, you're interfering with your dopamine levels in your brain, and it really impacts several areas. But the prefrontal cortex, your area responsible for like making sound decisions or like ethical decisions, like day-to-day things, is completely impaired. Like it comes down to, all right, I have drug or I can go to work. No work today. I can go see my kids or I could stay here with drug. I'm doing that. Food? Drug. So the day-to-day, like the things you look forward to every day, like seeing your kids, going to work, well, if you like going to work, but day-to-day functions, when those become impaired, when you're not even, able to make those decisions, where your brain is just telling you, you don't need any of those, all you need is the drug. Like, just keep using it. And when I went to a clinic, I saw it, like the amount of like self-harm someone will go through to the point that just to get the drug into them. I saw what happened when someone was injecting like cocaine and cocaine is not an opioid, but similar mechanism of how it affects the brain.
In terms of the addiction
Yeah,
development.
yeah. So I saw what happened to their arm. They were injecting it into their arm. You ever go to the grocery store and you see the really high-end cheese with like the craters in it?
Yeah.
That's what someone's arm looked like. Their whole arm was just covered in like pores and like rolling hills, it looked like. And it's like, you think about like, wow, like what state is the person's mind in at this, like, and often they want help, they really do, but it comes back to stigma and accessibility and shame. But
it seems like stigma is a big issue in mental health in general.
Oh, yeah, it is.
Not even just like talking about substance use disorder, but the people that are depressed or anxious or schizophrenic or things like that, they're very reluctant to seek help for it because of the stigma associated with it. But the way we're starting to learn it in like medical school, pharmacy school, is that it is a disease state. It's not like a given choice. Like someone can't decide that I'm going to be anxious and then you say, oh, don't worry about it, and they're going to feel better. Like there's actual like biochemical malfunctions going on in people's brains.
And that's the other way I tie it back to when someone is saying like, oh, like they're doing this to themselves. A lot of people, they're like perfectly fine. And then they come in contact with the substance. And there's like a lot goes into it of like, it's primarily like genetics, and then just some kind of, like you were saying, like if there's some kind of abnormality with the brain as a whole, like those are two really big risk factors for it. So like, and the example you could use is with alcohol, because pretty much the same mechanism, different, not entirely the same, but in terms of addiction. So let's say you and I go out to a bar which I can't remember. I don't think I've ever gone out to a bar with
I usually
haven't either.
Yeah.
usually show up to Beer Boys for like 5 minutes once a year.
I'm a big fan of like, all right, I'm here, bye. But anyway, let's say you and I go out. You have a drink, I have a drink, and we have a couple of drinks actually.
Ooh.
Oh yeah,
Well, maybe a Malibu Bay Breeze.
Yeah,
I don't like
whatever you want, whatever you want. You can have whatever you want. The key,
give me the girly drink.
Okay, all right. The key is, I'll get you a Truly. The key is that there's alcohol in it. So let's say we each hit our limit, and it's for you, it's horrible. Like you're throwing up. You're like, wow, this is the worst thing ever. I'm not going to do that again. To me, I go, wow, this is amazing. I can't wait to do this again. I'm going to do it tomorrow. I'm going to do it the next day. Keep going. And that's part of the, that's with alcoholism. I'm just trying to use it to more like, that's like a socially acceptable thing, right? You don't really think much of it.
Yeah, and there's actually, I don't know how true this is, but there's actually like, there are biochemical differences in people's bodies. So like some people have more of the enzyme called is it acetaldehyde or
aldehyde dehydrogenase.
Aldehyde dehydrogenase. Yeah.
Medical people. Yeah.
Which breaks down ethanol into
so it breaks down alcohol dehydrogenase breaks down alcohol into the acetaldehyde, which is the toxic thing in your body and makes you feel like crap. A lot of people, everyone has it. Some people have more of it. Acetaldehyde dehydrogenase. So if you have that second enzyme, if you have a ton of it, you'll quickly convert all that toxic stuff and you'll be fine.
You're lucky.
If you have if you have a little bit of it, you get that hangover and you get longer hangovers and more severe hangovers. So the people that have a ton of that enzyme and can quickly process it, they are more likely, so this is what I heard before, I don't know, I didn't cross-check it or anything, but are more likely to develop a dependency on alcohol because it doesn't have those negative effects. And then there's a drug you can actually give, antabuse, which is disulfiram, which blocks that enzyme and makes people feel those hangover effects. So like whenever someone's taking antabuse and they're drinking alcohol, they're not processing that acetaldehyde and they're just feeling like crap and it makes them not want to drink anymore. So it's like one way of targeting to stop addiction with alcohol. But that's like one of the ways, just like something I knew off the top of my head with like alcohol use, is that people can have more of that enzyme. Like it's a biochemical thing you can measure in people's bodies that will show like more of a tendency to become addicted to that substance.
Yeah, and just kind of going off what you said, with alcohol use disorder, it's like the same thing. You look at when someone actually has the disease, you look at impaired daily function. You look at when someone no longer enjoys doing the things they once did, no longer going to work, they're no longer social. Like a lot of these diseases, they work in a similar way in the brain, ultimately replacing the drug, whether it's alcohol, opioid stimulants, with those everyday life activities. Like that's what your brain is telling you need. And bringing it back to the choice thing, like when the brain is just telling you that's what you need to survive, it's almost like that fight or flight simulation, but your brain tells you that's your way out. So it gets much more technical than that, but ultimately your decision making is impaired. And like, well, someone might say, what about the first time they use it? Yeah, there is a bit of like it would be, you can't deny that there is a little bit of initial choice involved, but that's where you talk about risk factors too. So like people who are around substances all the time or like growing up are far more likely. People in like the LGBTQ community, more likely. People with a mental health disorder, like mental health first off is just, we do not have the means to right now. Like we really need to, we're kind of getting there, but we need to put more efforts into it because lack of providers in that area right now, like you can't wait months to get in for that kind of thing. Like I've dealt with it as a resident assistant. Like my first 2 weeks in, I had a student try and commit suicide, and it's tough stuff. And that's like an acute situation, but that's someone who they were going to services, but the services they were going to were not enough for to get them in a good place. And fortunately, that person made it out of it. They're no longer a student here. I think they took some time off, which highly recommend doing that. They like the school obviously wasn't a good environment for them to be in for that, but it's just like it just shows like mental health, substance use disorder, whatever you call it, like it needs more attention. Even though we're starting to kind of tackle it. Like I went to an event, and it was an naloxone talk at it was a middle school. And there were these drug and alcohol counselors, they called them. I don't know about that, but that's what they called them. They came and talked after us about vaping. And they were like, oh, we're just starting to get over this whole opioid thing, but now vaping's the new thing in here. And it's like, whoa, hold on here. It didn't go away. All the people that died, like they're still dying every day. Like, yeah, vaping's an issue too now.
What is it, like 12 people in PA or 60? I forget the number that like die from an opioid related overdose each day or something.
Oh,
like that.
yeah, they
I'm blanking on my stat, but it fluctuates around that number.
Yeah, it's currently around 12. Yeah, throughout the state, it's around 12. It used to be at 16. That was when it was. That was 2017. I think was roughly 16, and now we're down to 12 a day, and that's what Frank was talking about with a decrease in deaths. And what it was actually, I thought this was kind of cool, like to show like the impact that's being made. The courthouse right down the street, they had up on, there's the Opioid Awareness Day, they had the number of people that had passed away. And then for this year's, what they did was, they crossed out the number, like you could, like it was almost like they painted it. It was all like done on purpose. It's not like it was the old one they just redid, but they crossed out the number and wrote the new one over it that was lower. So I thought that was cool to see, like, yeah, what we are doing is making a difference. Yeah. Like I think in the county last year it was like around 100, so it was lower, the one that was on there, but it was kind of cool to see that. Like it's just like no matter where you go though, like anywhere in the country you can go, and it's there. Like it's like alcohol, it's like mental health, it's everywhere. Like it's not just stuck in one area.
Yeah, and I'm kind of stealing Dr. Franco's verbiage here since it's fresh in my head. Yeah. But something that he said that I guess confirmed or reaffirmed a pre-existing belief I held is that for things like substance abuse disorders and addictions and mental health disorders in general, it's both like the most fair and the most unfair disease state in that it does not discriminate by rich or poor or skin color. Like the only thing you could maybe bring up is like the varying genetic predispositions that could lead to an addiction, but by and far, even if you or an immediate family member is not suffering from something like that, if you're listening to this, you know someone. Oh, yeah. Probably someone close to you, whether extended family or immediate family or a friend that is suffering in some way from a mental health disorder or a substance abuse disorder. So it's like that taboo subject that you don't hear brought up every day, especially if you're not in healthcare, but it's all around you.
So kind of going back to something you said before when you're talking about like diagnosing one of the like substance use disorders, and you're saying, well, people are losing interest in, their job or their kids and all that kind of stuff. It almost sounds to me like it's like a depression, that like it's causing depression for people. Like
I never thought about it that way.
In a way like that alcohol also causes liver damage and cirrhosis. It could be doing the long-term effects on your brain and causing depression. Well, and then there also goes the opposite way, that depression can lead you to wanting to use alcohol or opioids or anything like that. So it's kind of tricky to figure out like what's causing this to be able to tackle it, and then at the same time, like cold stomach. But it's like at the same time, it's like, how do we tackle an issue like this if we can't really figure out what the root cause is?
Right. Yeah, it is tough. And that's something that I've been trying to figure out with our chapter here, because it's like, all right, we do all these things after the fact. Like, have naloxone. We have like the treatment for it. But what about like preventing it? And yeah, we have like our take back events to prevent someone from using like prescription opioids or stimulants, whatever. But yeah, there's no real like, it's not like like when you hit a certain age, sometimes they screen you, for like, they might test you. Yeah, exactly. They don't do that for this. They don't do that for like mental health, really. They don't do that for a lot of diseases. But that might be a way around it. But yeah, and going back to the mental health side of it, if the long-term effects of like having a substance use disorder untreated can lead to things like schizophrenia, depression, and those are all like predispositions to get the disease too. Like, and like what Colt just said, like, yeah, like anybody can be affected by it. Like I've lost family members from it, and that's like the reason I really got involved with it. It was almost like a wake-up call. Like I feel like I didn't do enough, or like I could have done something. So, and that's been, in terms of prevention, it's like just getting the word out about it, like talking to people, like even if it's like someone who's drinking a lot, like if you see something, like just talk to them about it. Just ask them about it first. Don't just tell them like, oh, I see you're drinking like 6 beers a night. What's like, why are you doing that? Like, just ask them how things are going, if something's going on. You don't have to exactly bring up the alcohol. And like the AA book, I'm actually reading the AA book right now. It recommends like, don't tell them to read the AA book, just leave it out somewhere. And then maybe they'll look into it. If it's someone who is an alcoholic or a person with alcoholism, whatever you want to call it. Put the emphasis on the person, not the disease. That's why we call it substance use disorder. That's why we call it alcohol use disorder. We don't want to use abuser, abuse, addict, druggie, like those words, no bueno. But
for the purpose of playing devil's advocate.
Oh boy, here we go.
Because I can't resist. I don't want to say a lot of time thinking about, but probably more time than others thinking about how, bear with me because I promise I'll wrap this back around, how in society today, we very often get caught up in the political correctness, if you will, of a word, because we don't want to steer someone away from, feeling included or, feeling offended, so on and so forth. But I guess I'm beginning to rebuttal against my own devil's advocation here, but do you think there is a place for that sort of careful word choice in talking about substance abuse disorders, not because you're worried about, not because you're trying to play the political correctness game, but instead you're trying to guide them to a decision that makes them feel like, they're a part of that decision. Do you know what I mean? Like,
kind of like almost as if, I feel like I had it in my head. Like, I mean, the part I would come back to with it is it's almost like providing someone education by not providing them education, if that makes sense. Like when you say addict, like at least in my brain, when you say addict, the first thing that comes up is someone trying to get high, someone that's like purposely doing this, someone that's, harming themselves. But when you say person with a substance use disorder, it's like, all right, they have this condition. It's a person with this condition that may or may not be getting treatment for it. But I don't know. It comes back to stigma reduction too, like to be more, I get what you're saying with like being more accepting of it. But it's almost like a different context. It's not like accepting in terms of like, and I'm not trying to offend anyone by any means when I say this, but like, just replacing some of the terms in like the LGBTQ community, like it's like a different form of exception. It's not like we're saying, oh yeah, we're just socially okay with people having, or like continuing to use a substance. It's more of like, all right, here's another way of looking at this disease, and more so, showing that it is a disease rather than just like the choice thing, if that makes any sense. I'm not sure if I answered it. I think I know what you're saying. I feel like
I really don't know the answer.
Well, are you kind of saying like more like steer them to realize that they have an issue but it's not their fault. But like
Yeah,
the internal like realizing that there is something wrong.
Yeah.
Yeah, that's tricky. I think a lot. I don't know. I can't speak for most people, but I think a lot of people, at least the ones that I've met at the free clinic or in Pittsburgh in the hospitals, I think they all recognize that they do have an issue with substances, or a lot of people let's just take depression for example. Someone that's depressed knows they're depressed.
Yeah.
It's hard to get out of that.
That's step 2.
So yeah, so I think using the terms carefully is not so much maybe to steer them to realizing that there's something wrong, but I think it lets them feel more inclusive with the provider, with the pharmacist, so that they can open up a little bit more and hear out the issue, hear out like what are their treatment options, how can they go about it. If someone comes in with substance use disorder, with alcohol, and you come in, you say, oh, you got this alcoholic coming in, he's abusing all this stuff, and they're not going to sit down and have a genuine chat with you about what's going on. But if you're taking the time to sit there and empathize with them, I think they're a lot more likely to talk to you and work on getting their life in the right direction.
Yeah, there is some evidence with like the recommended terminology that like more using that gets more people into treatment, like recognizing it more recognizing it as a disease. And all this stuff, if anyone's ever curious, if you guys are ever curious, it's through SAMHSA, Substance Abuse Mental Health Services Administration. Is like they're like kind of like the global like recognized body on a lot of the substance use disorder, alcohol use disorder. Like they're the ones who, like when we learned about the DEA number, you need the X for buprenorphine, which buprenorphine is used to treat substance use disorder. They're the ones that are like, okay, yeah, you're good. So like they have a lot of weight in this, and they're the ones who put out the terminology. But if you ever want to look at like some of the evidence behind it, their website has a lot of some really interesting stuff on it.
Something that's interesting to me is I don't think a lot of the providers and a lot of, definitely not the pharmaceutical companies, don't really take, I don't know if credit's the right word, but like responsibility for what,
I got it.
If you look up any like the statistics, I think it's somewhere around 70% of people that get addicted to opioids started with a prescription drug from, I don't know if it's maybe,
I don't remember the exact.
It's pretty high though. A lot of people, whether they start with a prescription drug from themselves or if they got it from someone else that it was prescribed to, I think slowly we're starting to realize that, we got to stop prescribing so much of these. And there's like those checks and balances on on like any sort of EMR now. When you type in, you have to type them into the state record system and all that. But I don't know. It's just I feel like the pharmaceutical companies kind of need to own up to it a little bit more.
There has been some, I don't know,
slaps on the wrist.
Yeah, like so it really is like a combination of things with maybe not prescribing safely, manufacturing. In the 70s, these things were manufactured. OxyContin, which is, potent. It's the whatchamacallit, extended. It's the extended. I'm trying to remember. Yeah. So, that was marketed as a non-addictive opioid in the 70s, which we know we went through pharmacy law. That's completely illegal.
Yeah.
And
it seems like they all start like that. I know whenever Dilaudid came out, that was supposed to be non-addictive.
Yeah, like that's the thing. Like these companies, they wanted to, have the advantage. And Franco talked about this the other day.
Is that Purdue Pharma that got?
So the thing about Purdue is, they got a slap on the wrist. So Purdue Pharma, they're responsible for a lot of the opioids that were marketed as that. Purdue also now, because I realized this at work, they make buprenorphine as well, which is one of the medications used to treat substance use disorder. So one way or another, they're still making money off of it, which it is really sad. I didn't realize that until we have to pre-pack things at work. Everything has to be unit dose because I work in a hospital. And I'm looking at the bottle. You have to type in the manufacturer, and I see Purdue on it, and I was like, oh, you got to be kidding me. Like,
I know. Something that Dr. Franco brought up that I didn't exactly put into perspective before is that I remember learning in pharmacy law that Purdue got fined by the government, like
yeah.
hundreds of millions of dollars, and you think like, oh wow, they are being held responsible for what they introduced into the world. But when you realize that the profits are in the billions of dollars, you realize that hundreds of millions don't really matter
No, that's
to
nothing.
that company.
Yeah, no. And again, going back to it, like there's a lot of like contributing factors to it, even on us, like as pharmacists, like just filling a prescription and not doing anything about it. And there's really been a shift in practice towards instead of just filling prescriptions, having it be more quality of life based, like more like health outcomes based. So we're getting there a little. And I feel like that might be an area though where it's like what we say we should do is not what's being done, because you don't have time to talk to everybody. You physically do not, and it's like oh, we should do what's best practice. Best practice is to counsel every patient on all their medications. You don't have time for that. Like you just don't. Like it is sad to say, and I don't know. Sometimes I'm a little skeptical of some of the statistics like pharmacy puts out. Like even for us, it's like, are we really like reaching that many? Are we really like talking to all these people? Sometimes I think it's more of like, I don't know, the reporting might be a little
Convoluted.
Yeah, and I'm trying not to be too skeptical about it. It's just like what I see in practice is not what's always followed through. So it's like, I don't know. So I feel like maybe when I'm on Appies or something, when we go in our rotations, I'll see. But sometimes I just need to see something. I'm a very like visual, like I need to see it to believe it kind of thing for some things. It depends on what it is. But like something like that is, I haven't ever seen it done, so I want to see it done, and then maybe I'll get into some of the statistics. But I have to be, can't be a hypocrite then, because I like refer back to statistics. So like, oh, this is evidence-based. This is shown to do all this. So you have to be, it's like a fine balance almost.
So if we are spitballing and trying to find the balance between, in a perfect world, we counsel every patient, but we can't. In an imperfect world, we streamline it to the point where we're just focusing on dispensing medications. We aren't counseling anyone. How do you filter out then what patients do you talk to? Like, what can pharmacists be doing then to find the most at-risk patients for developing like a substance use disorder, or find the patients who are most likely to benefit from talking about naloxone with?
Yeah, well, honestly, going back to what I said earlier, everyone who's getting an opioid, whether it's short-term or not, offer them naloxone, because it's not going to hurt anybody. The only thing is if someone has been on
if we are rephrasing that then for all the many non-pharmacists and non-future physicians listening, would you say it is a pretty safe recommendation then that for anyone on an opioid prescription 100%. To then ask about naloxone?
To at least bring it up, because if you look at the benefits of it, saving a life compared to them potentially dying, like it goes back to the warnings of the medications. It's a warning with it of respiratory depression, like not being able to breathe, no matter what. It doesn't matter if you've taken it the first day, you've been on it for years, like they decrease respiratory drive. So like even someone who gets, like let's say they get pneumonia, or let's say they develop asthma, like those right there, those are actually two, like if someone has impaired respiratory function already, that's where you bring something like this up too. And you use like our prescription drug monitoring program. It's not used to target people, it's more used to guide decisions. So anytime an opioid prescription is filled, for those that aren't aware, it has to go through the state database, and you can see when something was filled, where it was filled, the pharmacy, the provider, the doctor who wrote the prescription, how much it was, what it was, like everything is on there. And you kind of use that sometimes to help guide you. So like, I'll use a typical example. Someone who's coming in early for their prescription every month or every 2 weeks.
Meaning like they got, say, a 30-day supply filled, but they're coming in for a new refill in only 14 days or something like that.
And you have to be careful with it, because someone may have tolerance. That does not mean they have a substance use disorder, because you could bring it up and they may just have tolerance. Tolerance is part of having substance use disorder potentially, but tolerance does not mean substance use disorder, if that makes any sense. Like there are just like over time, your body is going to adjust to it. So there are people who say like, oh, like it says PRN for or as needed for breakthrough pain. Well, I had to use it for my breakthrough pain. Now it takes 2 to get what was 1. So in those cases, that's when you actually look at removing the opioid. Like opioids have no efficacy for long-term use. They don't. It's like they're like last option, like for chronic pain anyway. The opioids aren't they're not your friend, because eventually over time they may actually increase the amount of pain your perception of pain that you're experiencing. So,
and from a lot of people that I've talked to that have used them for any sort of pain, they'll kind of describe it as like, it doesn't take the pain away, it just makes me not care about it as much.
It depends on the person too. So like some people, like when I had it for my wisdom teeth, I didn't feel anything, which is probably for the best. It's like, all right, good. I chuck these things, get them out of the way. But some people they just get knocked out by them. And that's how some people just die from one dose. I mean, most prescription ones, probably not, unless they have like impaired like respiratory function. So in that sheet that I had mentioned earlier, let's talk about naloxone, it actually does have like a list of like patients who may have additional risk factors that you would want to talk to naloxone about or talk to about substance use disorder. And it is a tough conversation to have, and noticing patterns. That's what you really look for, like patterns in behavior, like they're coming in early, or maybe when they do come in, they don't seem like themselves. You almost have to have a rapport built with that patient to really see if there's a change in behavior. But again, it's like you can't really talk to anybody or talk to everybody. So maybe noticing those behaviors in a community pharmacy setting. The only practical ways to do it, it seems, are, using that PDMP, looking at refill patterns, and then just seeing how they are when they come in. Like, it may be easier in a primary care setting, but it depends, because some people don't go to their primary care. Or if they do, they don't really see them much. They stop in, and it's more of like they see the nurse. They may not actually. There's just a shortage of providers. I'm sure you both know that. Like in the state, I looked at not the state, the county. There's 1,200 people per every one provider in this county, and it's like, well, it's like, and you're thinking like, oh, that can't work. Well, no, it doesn't work, because people don't go see their PCP; they go to the ER for their primary care. But
where we're from in central Pennsylvania, it's like something like 4,000 or 8,000.
Oh, really?
To 1, for providers, and I think mental health providers was something like 8,000 to 1.
Oh, I'm sure.
It's so. There's an insane shortage. I don't know how to really address that. Although one thing that's interesting is kind of tangent, but our boards exams for medical school, the step 1 of the boards, the first one we take after second year, is now becoming just pass-fail instead of a score. So it'll open some doors for people that maybe want to go into different specialties.
Yeah.
So I don't know if that'll hopefully draw more people into wanting to do medicine. I mean, it's kind of... I don't really know like the main point of making it pass fail, because I don't think there's like a shortage of applicants in medical schools. It's just that there's a lot of filtering that goes on. So
right,
I don't know.
And there's more like, PA schools. The amount of PA schools and when someone thinks like 5 years compared to how many years in total? Like it depends, right? I guess
it depends what you want to do.
Minimum,
8 minimum.
Like, who knows for the amount of.
Like that's crazy. Like that really is crazy to think like. That was a big factor for me, because I was like, I contemplated going to medical school for a long time. I was like, that seems like, I think that's what I want to do. I'm glad I didn't, because I don't think I would have handled it well. But it's just like, it's a lot. Like just even thinking about it, you're in high school, it's almost like you're not even really ready. In my eyes, it's like, I don't know if you're ready to make that big of a decision. It depends on the person for sure, but it's like, do you really know what you're getting into? I think that's why we have like high dropout rates or high transfer rates in some places. But
there's a book I read by a doctor named Atul Gawande. It's called Complications, and he talks about some other countries that have different systems for medical school and pharmacy training and stuff like that. And there's pros and cons to everything. I think what he talks about is like, if you want to go be an orthopedic surgeon, and you're going to work on bones all day and extremities and stuff like that, in some of these other countries, you can go and you can start that right after high school. You start an orthopedic surgery track and do
Wow.
that for like 4 or 5 years instead of doing 4 years of undergrad, 4 years of medical school, and then 6 years or 8 years of orthopedic surgery stuff, and just to forget the first 8 years worth of information anyways.
Wow.
So I don't know. It's interesting. I mean, that could be a way to maybe tackle it, but
Mm-hmm.
the U.S. has such high standards for
Oh, yeah.
medical care that.
Yeah. That's why
But-
people come here.
Yeah, but I think even in the book, I think he talked about like the complication rates and things like that they were very similar.
Yeah.
Because I don't know, like if you're going to be an orthopedic surgeon, how important really is it for you to know all the GI pathways and all
You're
of
going to
this?
refer someone in those cases.
Exactly,
So,
yeah. Or someone's going to get referred to you just for
Yeah.
an ankle surgery or something.
Right.
Like it's a lot of wasted time.
Mhm.
But I guess I do understand the point of it behind it, like, getting the well-rounded, like, curriculum and everything. But there's a lot of time that goes into learning all this stuff that you just forget in the end anyways. I don't know, maybe that's a solution going forward, but
Yeah, maybe the semi-rebuttal to that, which I don't necessarily believe this, would be that at least when you do learn it and go through the process of learning that, even though you forget it in terms of not being able to recall it on a moment's notice, it's always kind of there, and that when you get really good at like finding the right answer and you have a knack in the future for what the right answer is, like you can quickly read it and be like, oh yes, like that is how it works, and so on and so forth. If you aren't practicing that, then it's hard for me to make that
Yeah.
case apply to an orthopedic surgeon.
like, say you're just doing ankle surgeries.
For sure, it's
Do you
hard for me
need
to
to
make that
know,
argument.
like, all of the pulmonary, all of
Yeah.
the, like, there's certain
True.
things you need to know. Like, you need to know that if someone's under anesthesia and they're going to go into respiratory arrest or something, you need to know how to combat something like that. But
Right.
do you really need to know, like, all this stuff about emphysema, all this stuff
Right.
about
Would we have to
COPD?
remove prescribing power then for
But when, like,
Oh, yeah.
but you
because
could,
they
you could make it-
technically could still prescribe
but like,
Yeah.
who's gonna? What orthopedic surgeon is gonna prescribe, like, I don't know, albuterol to
Right.
somebody? You know what I mean?
True.
Like, even if someone comes in and they're like, "Hey, doc, I'm about to get my surgery, but I've been having this asthma lately."
Mhm.
9 times out of 10, I'm sure that orthopedic surgeon's just gonna be like, "Yeah, bring it up with your
Mhm.
PCP."
yeah.
That'd be a good area to like research. Like look at, all right, do American like tracks of like let's keep it like, orthopedics compared to, either European, India, wherever it is, compared to those providers, is there a difference in like the outcomes? Like I
I
feel
want
like
to say there's not. So it's definitely in that book, Complications,
Mhm.
but it's been a few years since I read it. I want to say he said that the discrepancies in like actual like outcomes are
Yeah.
not
right.
not statistically even noticeable.
Wow.
But I could be misquoting that. I'll have to look it
Yeah.
up. We can look it up now,
Yeah.
but yeah, I mean, even if it's like a 5% difference, even
Yeah,
like
Have to
you're
see if
gonna have
it's-
so many more providers. You're gonna have so
Yeah.
much more access to medical care that people
Mhm.
aren't even gonna
Lower
get in
the
first place.
costs.
Lower the costs.
Lower the
everything,
costs. That'd be nice. Lower healthcare costs.
Yeah, that would be
Yeah.
very nice.
This
Yeah.
is a borderline not even productive to conversation to bring up. But as you're
cares?
talking about that, it reminded me of it's almost like an ongoing joke within the healthcare community, but something many people outside of being a healthcare professional genuinely believe, and that is when people are like, I see my doctor for like, my primary care provider for 20 minutes, and they went to medical school for how many years? They can't even tell me what's wrong with me.
Oh,
Like,
yeah.
like I go to see them, I pay them X amount of money
Yeah.
just for them to never know what's going on, or people have like some very complicated thing that has yet to be diagnosed that's like,
Mhm.
an intertwinement of,
Coronavirus.
autoimmune things or rolling out, oncology related things rolling out,
Yeah.
like things that we are just on the surface of learning about research wise, and it's hard to communicate how little we know, just on the science side of things.
Yeah.
So for physicians to not be able to immediately look at someone from the outside
Mhm.
and know what's going on in their body is like, to us it makes complete sense that like we we know enough to know how much we don't know.
Yeah.
But
So, yeah.
but to communicate that with someone that all they know is that this person went to med school for 8 years
Yeah.
and then did a residency,
Yeah.
it is silly too.
Yeah, and then the other argument, I think, somewhat rightfully so, the general public does hold like physicians to a higher standard and like, looks up to them that they should know all this stuff, which we should, they should. But you do have to remember that physicians really are just people too, like people forget things.
Can't remember everything. I've come to terms with that. You know where to find the information.
And if you're constantly practicing in like in a clinic that you're not seeing, say you're practicing in a predominantly like elderly community, and you're not seeing STIs or things like that, and then something comes in, you're not going to be so familiar with it from like a younger population, and I don't know, if you don't use it, you lose it. So that's another issue with healthcare. Maybe if we hyper specialize everything, but then
decrease the barrier to entry to becoming a physician, so that way you can jack up that amount of specialties. In the future, and going kind of way off now, I think artificial intelligence is going to have a pretty big role in the triage setting of it. Like if you can log into your, XYZ medical, company thing and type in all your symptoms and everything, and then the AI can run all these algorithms like this is probably the most likely thing, and then send you off to this certain doctor that's good with that. I think that would possibly be a solution in the future. But another thing is like there's all these great ideas and great things that could help, but a big problem with it is actually implementing it and getting it passed through Congress or passed through a law and all that kind of stuff. I don't know. It's like, how do you get the word out about your great idea?
It kind of goes along with...
not that I have any good ideas.
I doubt that. An example here in this situation is even like robotics with surgery. Like I would have thought at first that surgeons were like, no. And then I went to, it was like an event here. They called it a conference. It didn't feel like a conference. But they were like talking about the amount of like surgeons on board with it and the things that it lets them do now. And a big thing they talked about was even if something becomes automated one way or another, it will not replace the professional judgment of the provider. So some way or another, like I think the triage idea, that's actually pretty good. Maybe you could do that. Patent it right here. Trademark.
I don't know. I'm sure I've heard that. I don't think
but like even something like that, like it's automated now, but you still have your provider there. Like the surgeon is the one going in there and doing it. Like even though it's better. It's far better now. They're able to do things they weren't able to do. But like I don't know. I feel like pharmacy, like community pharmacy anyway. This is just my personal opinion on it, but I think something similar will happen in that, like a lot more automation. It's just...
I'm sure everywhere automation is going
to happen.
Burst probably quicker than we realize. A quote that I often think of that Peter Diamandis talks about is, the future is faster than you think. Peter Diamandis, I don't think I brought him up on the podcast before. He is an insane dude. If you have like a free 10 minutes at home and you just want like your brain to explode, just Google Peter Diamandis. Like he went to Harvard to get his MD pretty much just to like satisfy his parents, and then began pursuing like a career in learning how to first off like make his own private space program, so that way he can mine asteroids for resources. So it's like still in the making. He is I don't know if he's the founder or just on the small board of the people of the X Prize, where they award like millions of dollars to people to solve like the world's biggest problems. He started Human Longevity Inc., where they offer like full body, I think it's CAT scans to do like early detection of cancers and stuff that otherwise probably wouldn't be detected for several years from then, in some cases. And also run like full genomic sequencing of things.
That's going to be a big thing in the future.
Genomics.
Sure.
Yeah. So anyway, he has planted this idea in my head. I'm not saying I necessarily agree with it, but it's a fascinating thought exercise, that because of the advent of AI being integrated into medicine, stem cell therapy, genomics research, and being able to run full genomes pretty cheap the time we're born, and to know every disease we're, at least chronic disease, we're predispositioned for, and what drugs we will best react to, which is like that whole separate branch of like pharmacogenomics and so on and so forth. By integrating all those things together, he strongly believes that anyone that lives like 10 more years from now, or 10 to 20 more years from now, I forget his exact number that he throws out, will be functionally immortal, given that you don't die of some other like extraneous thing like a car accident or something. And he is someone that, that level of claim is not meant to be taken lightly. He is so ridiculously, eminently qualified in the space of like human longevity that it and AI and just like technology advancements in general, that for someone like of that, I don't know, like resume, to put that out into the world is crazy to think about. That maybe much sooner than we think. Like,
we're gonna get into a lot of ethics when that comes around.
Yeah,
but that's cool.
That makes me think of you had a quote up on your board the one day about, or no, it wasn't a quote, it was a picture you had, I think you put it on your story about like at what point, like, with expanding like the age expectancy, like to a point, like then we discover like a new disease or something that hits.
I sent this to both of you.
Yeah, like that. I was like, that made me think a little. I was like, oh wow, because then it's like goes back to like, oh, maybe it's something new. Like we never had to deal with it because people weren't living to be 130 years old. So it's like, wow.
So here's what it was. I was studying for an endocrine exam. This is funny you brought this up. I feel like this is like the epitome of how my mind works and why it takes me longer to study than other people. So we were studying for specifically this endocrine exam included menopause on it, and I was reading one of the intro slides, and I was talking about how in the early 1900s, menopause was essentially not even a disease state because of life expectancy in the U.S. was like, mid-50s or something, which is most often when menopause onset is. So now that life expectancy for women is like 89 or something, I might be like a couple years off. But in the U.S., now it is like a guaranteed thing that they will experience menopause anytime from, say, 50 to 60. Of course, there's some give and take with when that onset is. But regardless, now that's accepted as just like a guaranteed thing that will happen for elderly women. So something that my mind started thinking about while I was studying, and some rabbit holes I went down, is what, given that we are about to have this advent of stem cells and AI, jack our life expectancy up. Say that Peter Diamandis is wrong and we don't become functionally immortal in 10 years, but it would be hard not to think that our life expectancy couldn't go up to something crazy like 110, 120 within the next decade, given all those things come together and legislatively are allowed to be integrated into medicine sooner than later. What if there's I'm almost sure there are, even though I can't begin to predict them, different disorders like menopause that we see now within the endocrine system that, are like guaranteed to take place that we can't even like visualize now. Like maybe it's some neurochemical production just can't like happen that like drops off like after like 110. Like it's crazy to think about, and then gives an outlet for new innovation within healthcare. I know something you brought up that you can fill in the blanks better is, before we can even begin addressing that stuff, we have to really tackle the big bad problems of like heart disease and cancer and so forth before people can even be healthy enough at 110 for that to be the big problem to be dealing with. But it's
Yeah.
certainly a thought-provoking thing to think about.
Yeah, I kind of walked it back a little bit from there. Like, yeah, there's already a lot of people working on the heart disease and cancer and all that. Like, there's, it would be interesting to learn about what can come later, for sure. I mean, I don't know. Could you like start studying that in like an animal population? Like, I don't know. It seems like that's where all the studies always start, is like animals. But like, what really lives longer than people? Like turtles,
whales.
whales.
Yeah.
Yeah.
Is that like it? That might be it. Yeah, turtles and whales,
Yeah.
maybe. Wow.
So it's that's a tricky one then too.
Yeah.
Because you can't just automatically start studying like people. And, well, I mean, you could if you do it
Yeah,
like
you could.
non-invasive stuff.
Might be
but
hard.
yeah. I don't know. It's definitely interesting.
Cole, that's your job.
That's
Before we close the book completely, despite our rabbit hole on the substance use disorders, something you mentioned in passing was buprenorphine being used for the treatment of, specifically opioid use disorders.
Mm-hmm.
We spent time talking about the antidote to overdose, but not so much that treatment.
Mm-hmm.
What are your thoughts on using buprenorphine, which the brand name was the Subutex? And then if it's with naloxone, it's Suboxone.
Yeah, so...
because it seems to be a controversy, and I don't know enough in the space to like really... I don't have like a firm decision on it, but like...
Replacing it, like when someone says like
it is an opioid or an opiate, so it's like there's still potential for that high feeling.
And throw methadone on there too.
Oh, I will. All right, perfect. All right, so we've got your 3 go-to medications. First off, just for background, for treating opioid use disorder, are naltrexone, which is your injection. It kind of works like when you brought up like disulfiram, in that like if you use the substance while you're on that, you're not going to have a good reaction. And it's actually used to treat alcohol use disorder too. I kind of don't like that about those drugs, is it punishes someone for having a disease. But anyway, so we've got naltrexone, we've got methadone, and then we've got buprenorphine. So the typical argument that comes up with those medications are you're just like substituting one like substance with another. The thing with this is like these are the medications used to treat a disease and ultimately get someone off of them. That is the end goal. Now, it's not too... The thing it's odd about them, I guess, is there's no like specified duration of therapy. It's more so like patient specific, like when they're ready, that kind of thing. When I shadowed at a clinic, there was actually someone who was coming off of it. So it depends on the patient, and there's ways to get around. Buprenorphine on its own can technically be used to still get those euphoric effects, because the way it works is it's and I might be a little wrong here. I didn't brush up on it beforehand. I should have. And anything I say, I am not a licensed pharmacist. I'm just going off of memory here. But I'm not giving anyone healthcare information by any means. But it's a partial agonist/antagonist. So it's supposed to prevent those feelings of euphoria without someone going through withdrawal. Because one of the goals of therapy with treating opioid use disorder is to avoid withdrawal. Because if someone's going through withdrawal, they're most likely going to want to use the substance because it gets rid of that. Think of like, I don't know, your caffeine headache with like the worst stomach ache of your time times like 100. Like, it's terrible. Like coming off of substance, cold turkey, like you don't do that. Like,
so withdrawal from opioids is not lethal, right? But withdrawal from alcohol, you can actually die from that. And
because of the tremors.
Delirium. Yeah, so that's the thing about, you have to watch out with someone who is, if they're an alcoholic, you don't want to just, I mean, you could try, they'll probably find a way around it if you just try and cut them off from alcohol. If they're a really hardcore drinker, like if they're having like a lot every day for years at a time, if they just stop, they could experience delirium, tremors, seizures, and possibly die from it. So that's why you want to get someone in the treatment so they can taper off. But anyway, going back to the medication. So the way you get around someone abusing buprenorphine is people should not be on plain buprenorphine. They should be on Suboxone, which has naloxone in it. So it's buprenorphine and naloxone, because naloxone will prevent it from having those euphoric effects. So in those cases, you're preventing withdrawal and you're preventing euphoria. So no, they're not getting that good feeling out of it anymore. The only time someone should not be on Suboxone is if they're pregnant. Then you'd give them buprenorphine. And then if someone's in a hospital setting or in an area where it's being overseen, then buprenorphine or Subutex, which is the little films, that's more appropriate.
Right, they have those in like the orally disintegrating tablets.
There's
too,
orally
right?
disintegrating. There's the little sublingual film. There's the tablets. There's a patch, the Butrans patch. That's good for, you could treat pain with buprenorphine too. It can be used to treat pain. More so if someone has a substance use disorder, if they're experiencing chronic pain still, you could give them the patch, or you could have them split the buprenorphine dose throughout the day. Like if they're taking 2 tablets, instead of having them take 2, like 1 tablet every 12 hours or whatever, have them cut that in half and split it up into every 6. That way they have more pain coverage. But the goal is to get them off of it. The goal is not to be on them for life, but some people may need to. It just depends on the patient. They're not new drugs either, by any means, but it's tough because there really isn't like an established like set duration. So you find the right dose that prevents euphoria and prevents withdrawal, and then from there, over time, you should try and taper the person off of it. And so you had asked about methadone. So methadone is the other one. So buprenorphine's one, naltrexone's one, and then methadone. Compared to buprenorphine at moderate to high doses, there's no difference in efficacy. So honestly, they should be getting buprenorphine. Well, they should be getting Suboxone.
Is there a safety difference?
Well, that I'm not too sure of. The thing about the methadone that kind of stinks is they have to go to a clinic every day to get it.
Given that it's for substance abuse disorder.
Yeah, so methadone can be used to treat pain, and then it can also be used for substance use disorder. So
it could be given not in the clinic if it was for pain.
For pain, yeah, but if that prescription says for maintaining opioid use disorder or preventing withdrawal, anything related to like substance use, abuse, whatever, you cannot fill that. It's illegal. They have to go into a clinic every day and get that. But in terms of safety, I'm not really sure if one is more safe than the other. I know that at low doses, methadone is it works better than buprenorphine, but at moderate to high doses, they found no difference.
Yeah, the only thing I can think of, and I'm totally spitballing here, is that at least by going to a clinic for the drug to be administered, you bypass the problems with a patient picking up buprenorphine. And even though it's written for take, one tablet by mouth once daily, they can, take a lot of buprenorphine to feel those euphoric effects, especially if it doesn't have the naloxone in it.
And then typically what they do, so each clinic may be different, but the one I went to, they only gave people a week's supply at a time, especially when they started off on therapy. A week. That's what they got. They had to come back.
Of the buprenorphine? Okay.
Every week they had to come back and get a new prescription. They, typically they do have a urine panel. Typically they do screen them to see if there's anything else going on. Like some of the patients I saw, there were some that were still using. And the thing that's important, about
for those listening, the lights, it's the good old Wilkes University motion lights that keep going out.
It's a green building, I think. But anywho, they may still be using, but it comes back to like, all right, let's identify the triggers, like what caused you to use, how do you feel about using, like that sort of thing. It goes into motivational interviewing. But to answer the question, the bottom line, it's not like you're giving them a substance that is allowing them to progressively worsen their disease state. Typically, these are used to get, get people off of these substances. And I wish, too bad we're not at the whiteboard. I wish I could draw it out. So like sometimes people have this idea of recovery and it being like a straight line. Nope. Some people, sure, yeah, that might happen, but it's more
a
like
lot
a
of
zigzag.
oscillation.
Yeah, zigzag. We went in a circle. We came back. It's like
Meaning
yeah.
because of
The
relapse.
relapse issues that come up. And the pharmacist I was shadowing actually is someone who was in recovery. Like he talked about when he was in pharmacy school, he was using it was a prescription that he was getting from the pharmacy, not legally. He never injected it, drugs, but he had talked about like what it was like and his recovery. But when he's with patients, he doesn't bring it up because he doesn't want to take the focus away from them. He doesn't be like, oh, I know how you feel. I went through this. I mean, yeah, you might have the same disease, but each person's recovery is different. Each person's circumstances are different. There could be similarities here and there, but to answer your question, it's not replacing it.
What's your opinion on the clean needle injection sites that people have?
Okay, so the thing about those is at first you think like, oh my God.
Can you explain that just super quick for someone that doesn't understand?
Yeah, so we have oh my God, if Franco's watching this, he's gonna kill me because I'm gonna like forget the proper terminology for it. But it's you may hear them call it in the media like safe injection facilities or needle exchange facilities. I think it's like comprehensive syringe programs is the technical term. So if Franco's watching or listening, I kind of remembered. But anyway, the idea is with these programs is you can go and obtain sterile needles
without a prescription.
You don't need a prescription for needles anyway. You technically can walk into a pharmacy and get them.
Right.
And the pharmacy, it's, I guess, up to their discretion. And I'll give you some statistics on it. But you look at like, all right, the person is asking for needles. That itself is a step towards recovery. That's something like, okay, I understand I'm using, and if I use a needle that's already been used, like that can be dangerous. So I'll go, like people who go into a pharmacy or go to a site to get needles, clean needles, are more likely to get into treatment and go into recovery. But so these programs, first off, they're illegal. Kind of. There's been a little bit of discussion on it. There's an article that came out that I'll reference. So they're it's like on the edge. Technically, like they're underground per se. Like they're not it's not like they're operating like on the streets. It's something that's kept on the down low. I believe there's one in Pittsburgh. Yeah. There's one in Philadelphia. And there was a recent ruling on the one in Philadelphia was the judge found that it was not illegal. It was a safe injection facility. So meaning the safe injection facility, I never went into that. It means that you could go to this place to use a substance in the presence of a medical professional to ultimately make sure that you don't die. But both of these programs offer more than just that, like just needles. They offer counseling. They have treatment centers, they have naloxone, they have the clean needles. And the reason we promote, I'm an advocate for it, you should be giving out clean needles because you're going to prevent the spread of HIV and hepatitis, which costs the healthcare industry millions to billions each year. So you could delay that and decrease healthcare costs. And it's a harm reduction technique. Like you're giving someone something they need as part of their recovery. It's not necessarily enabling them because here's the thing. At the end of the day, their brain is still telling them, use that drug. If they don't have a clean needle or if they have an old needle, it's not really going to make too much of a difference. One way or another, they'll use the drug if it's someone in that state of the disease. So offering them at least a clean needle or a needle that is not contaminated with someone else's blood, you can, get them help in some way. And these facilities, again, they offer these resources. It's more than just giving out needles. But I agree with them. I wish we're a long ways away from it being, I guess, regulated. Even though the judge found that the site in Philadelphia was not illegal, I think they're trying to overrule it. The city, but
I think one of the important things with it is it gives providers access to a patient population that's not necessarily seeking out medical care.
Yeah.
So you can, like you mentioned, there's all these resources that they get presented with when they come to inject. And, whenever they come off their high and they're right there and you can talk to them, hey, now here's how here's how you can start recovering from this, and here's how you can do this. I think it is really important that you can get access to those patient populations. But one of the big gripes that the general population has is, why are my taxpayer dollars would be going to, a druggie or something like that, right? So what do you kind of have to say about it?
Well, most of these right now, at least because they're not federally legal or legal at the state level, they are being, like the physicians there, the nurses, whoever happens to be, they're volunteering for it. Most of the materials, so the naloxone, the needles, any information they're giving out, that comes from harm reduction coalitions that are paying for it, which it's not like they're getting money from the state. So harm reduction coalitions are organizations that ultimately their goal is kind of to give someone resources who has a substance use disorder, whether it's naloxone, needles, information, like treatment referral, that sort of thing. It's almost like preventing like the secondary, I'm not sure how to best word it, like the other things associated with substance use disorder. So like, preventing HIV and AIDS and endocarditis. That's another thing with injecting drugs when they're not, if you don't have clean needles, like staph infections of the skin. So like it's not like the money is coming from the state. And sometimes I see when someone makes that argument of, like when we have the state giveaways for naloxone, like, my state dollars are going to it. Here's the thing, like there's 100 some people across the nation dying from it every day. If we had another disease, or if we had another condition, like if people were dying on the streets of bee stings, like hundreds of people every day, you think EpiPen might be free? Maybe. That's a tough one because EpiPen's a lot of money right now. I'm trying to like someone will make the argument like, why is my insulin costing me $100? Why is naloxone free? Technically, the naloxone's not free. Like the emergency department visit, it's not free. Like someone's still paying for it. It's not like all this taxpayer dollars are going to it. But at the end of the day, those are two different medications anyway. Like insulin's for a chronic condition, and naloxone's used in an acute setting per se. But yeah, I know. I see where people are coming from, or I hear. I don't know. I'm trying to use the right I don't understand, but I hear what you're saying. But I just try to provide them some information. Some people you can't change their minds, and I've tried to come to terms with. This is Neil deGrasse Tyson talked about this. It's like sometimes you just can't change someone's mind. You can provide them the education if they continue to argue with you. You can't always change everyone's mind, and that's just something I've tried to apply a bit. Is all right. I can't, I may not be able to convince everybody, and my goal isn't to convince everyone to come to my side per se with this issue. It's more so to provide education for people, to get the word out on it, just so they have an understanding of it. Because we talked about it earlier. Sometimes you don't know, and sometimes even when I was in high school, the idea of giving someone syringes was like, wow, that's enabling drug use. That's you're just enabling someone's disease. But that really isn't the case if you look at the CDC, with the sites that they were monitoring, they tracked how many people were going to treatment from going to those sites, and most of those people did. So they're still kind of new. There's definitely a need for more data in the area, and the legality, technically at any time these places could be shut down.
So speaking of underground facilities, treatment sites, do you know much about these underground guided psychedelic trips that people can do to get out of opioid use disorder or alcohol substance? Okay, because I saw you show me that picture before we started with those books, and one of them was Michael Pollan's How to
Mhm.
Change Your Mind.
Yeah.
And he talks about it in there, how people can use these guided, they're like guided by, psychologists,
Yeah.
psychiatrists underground. It's
Mhm.
not legal to use these psychedelic drugs such as psilocybin or LSD or,
Yeah.
I don't know, give me another one.
Like ibogaine.
Yeah, ibogaine. And it actually transforms these people's lives with this 10-hour trip or 8-hour
Mhm.
trip with a guided therapist, so much that they're just basically able to snap right out of their
Oh, wow.
use disorder
Yeah.
within a month or a few weeks.
Mhm.
Yeah.
So that it's a really promising looking treatment option for something like this, and they've studied it with depression.
Mhm.
I think they've studied it with anxiety. They've studied it with terminal cancer patients.
Oh,
Yeah,
wow.
one
Yeah,
of the
so-
most impressive studies that I looked at with it, and this isn't in an underground one, but rather a clinical trial that was done at Johns Hopkins under the program of Dr. Roland Griffiths, was using psilocybin for smoking cessation, meaning just stopping smoking cigarettes or using tobacco products. So currently approved on the market, something that all three of us have learned about, is Chantix or varenicline. So Chantix has the highest percent effectiveness rate of helping smokers stop smoking, with the 6 months after therapy, successful quit rate of smoking fluctuating around like 30% for Chantix. In this trial that they did with guided therapy with psilocybin, it was around 67%. It was almost perfectly like 2/3 of the people a year later.
Oh,
So
wow.
even using the marker a further time later than the Chantix trial, more than a year later, we're talking about like double the efficacy in absolute value, not by relative comparison.
Right. Yeah.
Like, which is absolutely mind-boggling.
Yeah.
And
I have to look
psilocybin,
into
for anyone
that.
that doesn't know, is basically magic mushrooms.
Yeah.
Right, it's
Um,
the active component of quote unquote magic
Yeah, and
mushrooms.
they isolate it out, and you can take it, and
Oh,
then,
okay.
it's like 6 or 8 hours or something. They're with this guided therapist.
Okay.
So in any of these things, like Michael Pollan, I'm sure with Roland Griffith, they don't recommend doing this on your own, like
Right,
self-treating
yeah,
it. You want to
yeah.
be in some sort of study like
Mhm.
this with a guided, like a professional.
Yeah.
But it seems like something that might really be able to,
Mhm.
it's talk about stigma. It's like if popular culture, like if society can get over the fact that these drugs were in the 60s and they were, there was such a bad, like just viewpoint on these
Yeah.
drugs for a lot of actually just misinformation.
Mhm.
If we can get past that, these things would be like amazing treatment
Yeah.
options. At least so far,
Mhm.
what we're seeing in the research. I don't know. There could be some big problem with them that we don't see right now, but
Yeah, perhaps that even gets into a more taboo area than the current substance use disorders at hand. But that's something we could have a conversation about for hours, I'm sure.
yeah.
Just looking back on, was it Nixon that administered the Controlled Substance Act in the I know the decade was like maybe I'm lying. It's either in the mid 60s or mid 70s.
65.
But regardless, before then they were actually having ridiculous efficacy shown, not just at Hopkins, but
Yeah.
like at a bunch of different sites
Mhm.
with the controlled, clinically administered
Yeah.
and guided psychedelic therapy. And then you have people like Timothy Leary come out of Harvard, pretty much, it's not like it was, snuck out of the lab, especially particularly with LSD, but he was pretty much like
He was-
giving it
yeah.
out to the general population under the like motto of like tune in and drop out or something
Yeah.
like that. Put a terrible face to the name psychedelics, and then we had like the Controlled Substance Act and this
No one's getting anything now.
and that war on drugs began.
Mhm.
And just until the past decade are we finally realizing that like, oh, we just looked away from all this marvelous evidence because of some very irresponsible person.
Yeah, I think Leary does catch a really bad rap. A lot of I think what he was trying to do is he saw this as like a miracle drug, basically, and the things it can show people. And I think he got a little too giddy with it, and
Yeah.
was just trying to give it out to everyone and not realizing that it is a very powerful substance.
Right.
And then so, like Cole said, TuneIn dropout. Everybody was kind of going against like the establishment. That's when you had like the all the
People trying to avoid the draft.
yeah, burning your draft cards for Vietnam, things like that, because people were starting to maybe like lean further away from like government, more towards nature and like love and all that stuff.
Hippie stuff.
Yeah, exactly.
Per
Hippie
se.
stuff.
Yeah.
So, and then the government cracked down. We can't have people doing this, so they banned everything, and that just got thrown in a box for the next 40 years, and it's slowly been servicing up.
Yeah.
I think Hopkins and maybe Stanford. Is it Stanford?
I know NYU has some
NYU.
ongoing stuff right now.
There's a few places that are doing some ongoing research, and they're actually enrolling. Like human participants.
To look into that.
Yeah.
Not to hop on board, but just to read about it because I don't know.
It is super interesting, and it would apply definitely to opioid use disorder because.
Yeah, the evidence is beyond convincing, in my opinion. And I'll add the caveat again that in no way do we mean the recreational, quote unquote party drug use of psychedelics, but instead the clinically administered psychedelics. And I wouldn't even say just for disease treatment and cures, but also there is studies put out by Hopkins on what they call a healthy normals population. And the wording of the study that was first put out, I think this was in 2006 within the Griffiths lab at Hopkins, but within a healthy normal population, and this is his words, not mine, the ability of psychedelic therapy to occasion a mystical experience is, this was also roughly around 70% of the participants more than a year later said that their administration of psychedelics in that setting was in the top 5 most meaningful experiences of their life, and like a third said it was the most meaningful experience of their life.
And that's these people are ranking that like alongside like birth of their first child, like my wedding day, like things like that.
So it seems like something to be taken very seriously and have reverence for, not to tell the public to go do this willy-nilly without being under the supervision of a trained clinician. But it's certainly something I think should be advocated to be taken seriously.
Definitely, yeah, for sure. I think it's something that I don't want to say like open your mind to it because we don't know enough about it. But I think people need to maybe not necessarily just as soon as you hear the word LSD. You hear the word
stigmatized.
Yeah, you don't need to immediately shut it out. Like at least
we need to know with like medical marijuana. It's kind of not saying it's the same thing, but like the amount of like diseases. I'm not an expert on it. I don't really know anything about it, but just like the amount of diseases that they use to treat it now, and even like you really want to blow someone's mind. I mean, there's prescription meth. Like methamphetamine tablets, like cocaine. Cocaine is still it's utilized as a local anesthetic. Good blocks of sodium channels, I think. Don't quote me on that, but I mean, just keeping an open mind in general, like just like reading up on it. I'll have to read up on those because
actually like the psychedelics are kind of following a similar path as marijuana as far as like legalization goes, because I think. Very recently, Denver and maybe the state of Colorado legalized psilocybin.
I would think
decriminalized. Sorry, decriminalized.
Yeah, decriminalized.
It's a big difference, But I mean, that's how it started with marijuana. It got decriminalized, and then it slowly medically legalized for medical use, and then after that, recreational. So I don't know. It's interesting to see what would happen with all this stuff.
I think the reason that people will be more supportive of psychedelics in that clinical administration sense is that my current standing on cannabis and like whether recreational or medical is that like even though I think it's compared to all the things that are legal, it's very benign. There's put bluntly not nearly as much evidence, not even a fraction of the like actual efficacy in helping disease states. Sure, it's been proven helpful in like reducing pain and so forth in different pain-related illnesses. But and in no way does it show the evidence of actually like curing these different disease
It's more like
states.
symptom management.
And you don't see people putting smoking a joint as their top 5 life experience.
Well, Harry, I want to be respectful of really everyone's time here. You and I have some studying to do. Nick has to drive to Pittsburgh today.
Yeah, I'm sorry to hear that.
But I want to acknowledge you and say thank you for coming on
Thank you.
and
Thanks for having
educating,
me.
as you said.
Yeah.
And where can people find you on the radio show?
Oh yeah. And I didn't like give out any information about myself, but I'm in Cole's class. Cole and I are in the same class, so I'm a 3rd year pharmacy student. Some people say 5th year. It's weird. 5th year overall, 5 out of 6. 3rd year. But if anyone wants to check out the Generation RX radio show, you can listen live. For you, that really, it will be a little hard, but there's a way around it.
Tune in or something.
Yes. So we have. So the station we're on is 90.7 WCLH, and that's like the Wilkes, Scranton, Hazleton area. On Thursdays from 9 a.m. to 9:30. It's a short show, more so because Dr. Franco has stuff to do. We have stuff to do. So 30 minutes each week. Sometimes we go long, but you could use if you just Google like Wilkes University radio station, you can find it. It's like the first thing that pops up. Click on it, and then there's a listen live. Or you can use the TuneIn app. You can tune into 90.7 WCLH on the TuneIn app. So we're on there. And then hopefully in the next few weeks, we'll get it set up as a podcast on the Wilkes Pharmacy website, and then maybe be able to transfer them over to a
Our lights went off again.
Yeah, so then maybe we'll be able to transition it over to like the actual, like either YouTube or podcast network, but we don't have any video. It's just it's a radio show, so it's just all recorded stuff, but you don't want to see my face anyway.
What about on any social media or stuff like that?
Oh, I mean, we actually don't really use social media too much, other than I'll advertise it on the Wilkes Pharmacy, our APHA, American Pharmacists Association Instagram. Just be like, hey, tune in tomorrow for this week's show. I've been bad about it lately. I wish I had control of the Instagram, because then every Wednesday, I'd be like, all right, I'm going to advertise the day before.
Yeah, I know Nick and I are very bad about staying active on social
hard.
media for the podcast and personally.
I try to do it through the schools, though. That's the thing. Like, I don't want to use my own personal ones for it, because I'm not trying to like put attention on myself. I would rather have attention go to the show. It's like it's not the people doing it per se. It's just the fact that like there is. Well, it does matter who's doing it, because depending on the person, they could be giving out a lot of wrong information. But that's why we always have a licensed pharmacist on the show. Yeah. Dr. Franco's usually on, or we sub out if he can't make it. Dr. Van Wert was on. That was a good show on toxicology. But it's more so just getting the information out there. It really does, because next year it won't be me doing it, unfortunately. It'll be somebody else, so it'll be sad, but it'll be a big weight off, because I have to write this freaking script every week. That's a pain sometimes when you have a million things going on. But
right.
Yeah, so.
Cole, you got your final question you gotta do?
I feel like I bounce around between final questions.
Well, I usually ask about
yeah. I would say this is my most used final question. Would be, is there any go-to book recommendations or documentary recommendations?
Podcasts.
Yeah. That you think people across the board can learn from? Not even necessarily about substance use disorders, but things that have inspired you.
If not, it's really
It
was like the conference I went to, but that's like a pricey way of doing it. I'm trying to think of like a good. I mean, because I was trying to think of like, when did I like transition into this? I don't have like a go-to like document or anything. It's more so of like just knowing someone. And I know this is like substance use focused, but if you have someone in your family, like just talk to them. If you have a friend, just talk to them. Like, I don't know. I wish it's something I had done before, like losing someone. Like, I don't know. I don't really have like a book or document. I've got a conference that I could recommend, but it's anyone can go to it, but it's like $300 and a flight to Utah, Salt Lake City. But yeah, I wish I had something. I really
No,
do.
you're good.
I mean,
I think that's a more powerful way to end
Yeah,
it, is
just-
that there's more people probably suffering from a substance use disorder than
even
you think.
if it doesn't even have to be substance use disorder, it could be like mental health, anything. Like if you know someone that's struggling with something, like just talk to them about it, and don't go. You don't have. It doesn't have to be like, oh, Harrison, how are you doing with your alcohol problem? That's not what I mean by this. It's just like ask them how things are going, ask them how they're doing, ask what you could do for them if it's something that if you're going to ask that, make sure you follow through and mean it. Don't just ask it or tell someone if they need anything that they can reach out to you and you don't do anything, because that's not good. But yeah, just I don't know. I guess that's how I'll end it. Yeah.
It's fun.
Yeah. Well, thank you
Thanks for
again.
coming on.
Thanks for having me.
Thank you, sir. I'll see you tomorrow.
Yeah.
Adios, everyone.
See ya.
All right, everyone. Thank you all for tuning in. Please track us down on social media. Our Facebook is Insights of All Trades. Our Instagram is at Insights of All Trades. Our Twitter is at IOAT Podcast. And you can find us on Gmail. It is insightsofalltrades@gmail.com. So please just send us in your insights. It would mean a lot to us and a lot to everyone else. Meaning, send in any tips or tricks you've learned through your trade or your passion that you think everyone would benefit from knowing. So until next time, adios.